Kia ora koutou, good evening. Thank you very much for braving the snow. I think snowshoes will be handed out at the end in case the storm comes through while we're in. Thank you very much for making the effort to come this evening. And listen to a talk that topic I could talk about all week, but I promise I won't. And hopefully by the end of the evening you'll realise why this is such a critically important issue for all of New Zealand. So, once I get my... Yes, here we go. The overview of tonight's talk is, first of all, briefly go over what is bowel cancer and why is it important, what causes bowel cancer and what treatments are available, and what's the New Zealand situation, and then something slightly topical, what about bowel cancer screening, and should we be doing that or not. So I'd like to start off by talking about briefly what is bowel cancer. So most people will know the large intestine or the bowel goes from the appendix all the way through to the anus, and you get these little wee things here called polyps which can form over time. If left, they can, and undetected, they can grow. This is the lumen of the bowel here, and here's a cancer of the bowel growing in. And like any pipe with something growing in the middle of it, it starts to become blocked and you get symptoms related to blockage from bowel cancer as it grows. Cancers as well are very fragile and friable, so they bleed easily, and you'll see some small amount of blood there on the tumour, which is why people with bowel cancer can frequently become anemic, and so fatigue can be a sign of bowel cancer from there. Ultimately, the tumour will continue to grow if unchecked to the point of occluding the bowel lumen completely, and the bowel will obstruct. As the bowel cancer grows, it not only stays inside the bowel, but it can spread to the adjacent lymph glands, grow into the blood vessels and spread through the blood supply to other parts of the body, which secondary cancer or metastases, which is almost, but not always, but almost invariably fatal. So that's what bowel cancer is. But why is it important? Well, cancer is the number one cause of death in New Zealand. It accounts for more than 30% of all deaths. And it's impossible for people not to be touched by cancer in one form or another, either in themselves or a loved one. For the last 15 to 20 years now, cardiovascular death has been dropping due to improvements in prevention such as blood pressure control, cholesterol improvements, reduction in diabetes, and reduction in smoking. And with all of those preventative measures, cardiac death is now on the decline, and as we get older, cancer deaths start to increase. And the problem's not going to go away in my lifetime, that's for sure. Of those cancers, about 4 or 5 cancers make up more than half of all of the cancer burden. So the 5 most common cancers are bowel cancer, breast cancer, prostate cancer, lung cancer and melanoma. Together they account for 60% of all of the cancers in 5 tumour types. For bowel cancer, more than 3,000 new diagnoses every year. 3,000 diagnoses. 1,200 deaths from bowel cancer every year. It's the second most cause of cancer-related death, and it kills more people than breast cancer and prostate cancer put together. Yet most people don't know that. So a very common problem, and common in New Zealand. So why? Why do we get bowel cancer? Why is there so much bowel cancer? Good question. Why is there so much bowel cancer? Well, there are a number of risk factors for bowel cancer. Yesterday, the Cancer Society supported a meeting that was about the relationship between alcohol and cancer. And, as much as I hate to admit it, as a man with a very good Pinot Noir cellar, alcohol is a risk factor for bowel cancer. For every standard alcoholic drink you take per day, if you took that every day, it increases your relative risk of bowel cancer by 7%. Every alcoholic drink, 7%. It's depressing. Depressing. I got so many messages from my friends last night going, "You've ruined my evening!" Tell me that. It's true. Personal or family history. Having a personal history of bowel cancer or having a first-degree relative with bowel cancer is clearly a risk. In particular, if a family member was affected at age under 50. So any relative at all who's first degree, so your mum, your dad, your brother, your sister, or your kids, affected by bowel cancer, your risk goes up significantly. And if any of you have had a first degree relative with bowel cancer, get a colonoscopy if you've not already had one done. Okay. Vitamin D deficiency. So vitamin D levels are strongly correlated with bowel cancer. So the lower your serum vitamin D levels are, the higher your rates of bowel cancer are. It's not yet clear whether taking a tablet can reverse that, or whether it's something with the cancer consuming the vitamin D or what. But it is clear that those with the lowest rates of vitamin D also have the highest rates of bowel cancer. Vitamin D is good for other things as well, like bone health, for example, and there are many reasons to take a vitamin D supplementation tablet, particularly if you live where I do, in Dunedin, where it's a bit dark, and you don't get outside so much. And so vitamin D levels are important. Smoking. Smoking is a grade 1 carcinogen, which means there's a clear link between smoking and cancer in general. Everyone thinks about smoking and lung cancer, but in actual fact, smoking is associated with a whole raft of cancers, including with bowel cancer to a small extent. Doesn't matter how you take the cigarettes, it's still a risk factor for lung cancer. Inactivity, obesity, diabetes, all individually risk factors of bowel cancer. So if you want to prevent bowel cancer, do more, drink less, don't smoke, just things that your mum and dad would have told you to do. Okay? The best cancer prevention things you can do. Microbes, I've put that up. Interestingly, a researcher in Christchurch, Jackie Keenan, working with Professor Frank Frizzell, has looked at the stool composition, the bugs in the bowel of people who've got bowel cancer and the people who don't. And what she's found is there's a higher rate of a bacteria called Bacteroides fragilis in people with bowel cancer than people who don't have bowel cancer. And their theory is that possibly there's a strain of Bacteroides fragilis, enterotoxic bacteria, which actually is directly toxic. So it may well be that part of bowel cancer is actually an infectious disease of sorts. Knowing this, we can then study what happens if you manipulate the microbial balance in the gut. So their research suggests that about 15% of people who have bowel cancer have too much of this bacteria. And the next phase of work will look at how that can be changed and manipulated for a better outcome. That's what causes it. The other question I always get asked is, isn't it all our red meat consumption? Isn't it because we're a country full of carnivores that causes bowel cancer? I've heard that red meat causes bowel cancer. Well, it's true that raw unprocessed meats are associated, red meats, with a higher rate of cancer, because the way in which they're processed or the way in which they're digested can lead to the formation of a toxin which can be directly linked to bowel cancer. But it's not quite that clear cut, because what this world map over here shows is the countries with the highest meat consumption in dark red and the lowest in the lighter colours. And you actually see that New Zealand is number 5 on the list of meat consumption, or all meat number 4, yet the United States has lower rates of bowel cancer than we do, and Australia has lower rates of bowel cancer than we do. So it's not just meat, it's all those other factors as well. So yes, too much red meat is a risk factor. A little bit of red meat's okay. They say a piece of red meat about the size of the palm of your hand is about what you should aim for. 3 to 4 days a week, and have white meat or vegetables on the other days. So what are the current treatments of bowel cancer? What can you do about it? Well, fortunately, even though 1,200 people a year die from bowel cancer, more people are cured. Okay, that's the good news. What do we do for bowel cancer these days? Well, first of all, for people who've got bowel cancer, which is just in the superficial lining of the bowel, you can take it off with an endoscope. Now, this somewhat barbaric-looking contraption here looks like a scene out of medieval England. Has got a camera going directly into the colon, and what you can see in here is the camera. They're looking at the tumour, lifting it up off the mucosa and dissecting it away. So that is a way of doing an operation for very early bowel cancers without having to chop down the middle and whop out a whole section of bowel. Otherwise, for other cancers which aren't quite so superficial, taking out the affected segment of bowel is the cornerstone of management. And for a number of patients, a colostomy bag may be needed, but not always. A colostomy bag is needed if you've got a very low tumour in the bowel, particularly in the rectum, or for some people who've had a very bad bowel obstruction, the bowel needs time to recover, so you can end up with a stoma bag. But it happens in less than about 1 in 4, 1 in 5 patients. So stoma is actually the exception rather than the rule. Stomas clearly have a significant impact on people. It's a pretty socially limiting thing to have, many people find. Occasional leaks, which are very distressing for people when they happen, of course. And so every effort is made to avoid a stoma wherever possible. The other thing about surgery is that quality actually really matters. The type of operation that you have. In the old days when we did rectal cancer operations, what used to happen was the surgeons used to get their big fat hands in there and sort of get their hands like that and rip it out, literally. And what they found when they did that was when they took it out, it looked like this Raggedy Ann specimen. It's a very rough specimen when they sort of ripped it out by what they call blunt dissection, which was in there with their hands. And what they found was if they did that, the local recurrence rates could be as high as 40%. So that is, even though you took the tumour away, it would come back in the immediate area around in up to 40% of the cases. And at that stage, it becomes very difficult to treat. So instead, what some other doctors demonstrated in the UK and also in Auckland was that if you did what was called sharp dissection in natural tissue planes, you could get this clean-looking specimen. I hope you can see the difference between this specimen here and this specimen there, and the local recurrence rates fall down to below 6%. Okay? So good surgery really matters. And if I ever have to have an operation, one of the first questions I'll ask the person in front of me who's proposing to do my operation is, how many did you do last year? Because those that do more do it better. What we also know is that after a bowel cancer operation, if there's some signs that the bowel cancer is spread, that giving chemotherapy after an operation quite clearly improves overall survival by about 10 to 15%. There have been a number of changes over the years in the type of chemotherapy we give, but it's largely accepted worldwide that giving chemotherapy after a bowel cancer operation where the bowel cancer has spread outside of the bowel, you in fact increase your chances of curing somebody lifelong. So a good standard of care in moderately advanced bowel cancer. And cancer which is spread to other parts of the body, so you've got secondaries in place, giving chemotherapy can over quadruple your life expectancy. So from an average of 6 months with no treatment to over 2 years or more by giving chemotherapy these days for advanced disease. So some great gains by giving chemotherapy, even if the cancers jump the fence beyond the bowel into other parts of the body. So there's hope for people who've got bowel cancer these days. Some of the potential side effects of chemotherapy. This is one of the chemotherapy drugs, that what it does is it causes drying out of the hands and feet, and it causes these cracks in your fingers, and that can be quite painful. And a similar thing can happen inside the gut, and that can cause ulceration of the gut and can potentially cause diarrhea. Many people, when they think about chemotherapy, they think, oh, I'm going to lose my hair and I'll be throwing up all the time. But in actual fact, that hardly ever happens with bowel cancer chemotherapy. People don't lose their hair and they hardly ever vomit, which is a great advance on what's been done previously. So again, a lot of advances in therapy for bowel cancer. What we know for people, again, whose cancer has jumped the fence, has gone to other parts of the body, is that year on year, bit by bit, nibble by nibble, we've made little wee advances in advanced disease therapy. So now, as I mentioned, the average life expectancy for people with advanced bowel cancer has more than quadrupled in the last 15 to 20 years. In addition to that, a small number of patients who have bowel cancer which is spread to another part of their body, such as the liver, for example, for people who've got an isolated metastasis, so 1 or 2 secondaries, if you take them out with an operation, you can actually cure people. And this is remarkable. There are very few cancers that I can think of, that we know of, where actually taking away a secondary spread, a secondary deposit of cancer, actually can cure people. And it does. In about 20 or 30% of patients who have these operations, they are cured lifelong. So the cancer says, I'm going to spread to other parts of your body, get through your blood vessels and spread down the arterial highway, land up somewhere else. We can still cure it by chemotherapy and surgery together. And that's pretty cool. These are some of the other things we do to people who've got very advanced cancers when it's spread to the liver. There's a picture of one of my colleagues doing an operation, and that's what the liver looks like in there. And this is the bowel underneath the liver there. What you can do is you can cut segments away from the liver. There are 8 segments of the liver, and you can take away up to 5 in any one go. And you can take away segments of the affected liver and still leave people with a functional liver, enough to have a drink of wine, and still leave people with a functional liver. Okay? We've got these things which look, I can't decide if it looks more like a kitchen whisk or a Dalek probe. but you can insert these catheters into people's livers through the skin, and that emits high frequency ultrasound or sometimes microwaves, and that can thermocoagulate the tumours and actually destroy them in exactly the same way as it would if you cut them open and cut out their liver. So this is done as a day procedure. Okay? It takes about an hour to do this procedure, as opposed to doing a huge operation. So for people who've got 1 or 2 liver secondaries, this is an excellent alternative to major surgery. So again, big advances. Now these giant basketballs here are actually resin microspheres, and the size of these microspheres is less than 1/3 the size of a human hair. It's tiny, and coated with a radioactive isotope called yttrium. It can be injected directly into the liver through the femoral artery back into the liver, and can deliver very high doses of radiation to the tumours, again causing significant delay in tumour growth and significant control in the liver over doing no therapy at all. And in Wellington, Richard Stubbs is one of the very early advocates of this procedure here. But what about New Zealand? How do we stack up in terms of these treatments? How are we going here in New Zealand? Well, what we know in New Zealand is that cancer is on the increase. The number of new cases every year is increasing. Now that's despite the fact that we're curing more people. So now more than 2/3 of people with cancer in general are cured, and that's improved by about 10% per decade. But because we've got an ageing population structure, the actual number of new cases increases every single year. Okay? So the number of new diagnoses is going up. So the amount of work for people like me to do, unfortunately, is higher every year. Good thing for my employment prospects, but perhaps not quite so good in terms of the expense of cancer care. And in terms of New Zealand's rates of bowel cancer, how do we stack up? Well, for females, we have the world's highest rates of colon and rectal cancer. The number 1 highest rates of colon and rectal cancer in women in the world. Okay? We are world leaders in women getting bowel cancer. Hooray. In terms of men, we're about number 3, so not far behind. Okay? So we are world leaders in this disease for all the wrong reasons. And in actual fact, the other thing is that in the last couple of years, what we've found is that our death rates from bowel cancer are actually worse than they are in Australia. So you are more likely to die from bowel cancer if diagnosed in New Zealand than you are if diagnosed in Australia. And that to me is terrible. We really need to unpick the reasons why that is, to learn how we can improve in terms of our bowel cancer cure rates. Why is it? Why are we doing so badly in New Zealand? Well, one of the first things is we don't talk about it.
Morning.
How are you, Rob?
Yeah, I just had my back passage looked at, thanks, Jane, and everything's fine. Yeah, I could have given them a stool sample, but it's best to let the doctor have a peek up your body. Apparently, there are no symptoms until you start bleeding from your rectum. And by then, it can be too late.
Bowel cancer. You don't need to talk about it. Just do something.
Got the doctor to have a look at my bottom. Through the bottom, goes in, through, and has a look.
Not quite as polite to the conversation as talking about breast cancer or prostate cancer, but you know, we need to get over it. We've got such a big problem, it's such a common cancer. We have to be prepared to talk about our bums and our bowel cancer if we're actually going to tackle this major problem. Okay? So talk about it. That's the first thing we should do. So you guys obviously already here to talk about it. It's great. So what are the factors that contribute to outcome? Number 1, higher rates. Number 2, diagnosis. Number 3, treatment. Number 4, comorbidity. And number 5, are there any ethnic inequalities in terms of outcome? So these are the key areas I'm going to quickly go over. Number 1, early diagnosis. What are the symptoms of bowel cancer? One of the problems with bowel cancer symptoms is that they're very non-specific. I think most women would know if you had a lump in your breast, you go to your doctor because it could be a breast cancer. Most guys would know if you've got urinary flow problems, could be benign prostatic hypertrophy, but it could also be prostate cancer, so it's worth getting checked out. Most people with bowel cancer symptoms, change in bowel habit, they tend to sit on their symptoms. Oh, you know, just a bit of dodgy curry, it's a bit of a dietary change, I'm just a bit bound up, and don't actually think about it more than that. But in actual fact, bowel symptoms are just as important as a lump in your breast, okay? So the symptoms you can get are a persistent change in bowel habit with a tendency towards looser stool, which persists for more than 6 weeks. Okay, it's a characteristic symptom of bowel cancer. Obstructive symptoms like abdominal bloating or feeling a lump, bleeding from the rectum or the back passage obviously are also potential symptoms. Anemia, becoming anemic as a result of the bleeding of the tumour, like I demonstrated on that earlier picture. Again, common features in bowel cancer. So the symptoms can be subtle, they can be non-specific, but it's important to talk about your bowel symptoms and it's important to get them checked out. You can have different types of investigations for bowel cancer. One of them is called a colonoscopy, so a camera which goes up your bum. And the other one is called a CT colonography. So this is a different technique where a CT scanner does a procedure from the outside. You still have to have your bowel prep cleaned out, your bowel cleaned out, and you still have to have some air inflated into your colon to expand the colon up a bit. But the colonography can in actual fact detect significant polyps and cancers with just about the same sensitivity and specificity as colonoscopy. And this is increasingly common and it's also a bit cheaper. And colonoscopy, in terms of getting access to colonoscopy, this does remain a problem. The New Zealand model of healthcare is that the hospitals get given a budget and then they have to work out how to best spend that. In America, in Australia, if you do something, you get paid for it. So in America, you sneeze or something like that and you end up with a colonoscope. In New Zealand, on the other hand, our access to colonoscopy is a lot more difficult than that. The hurdles you have to jump through, the hoops you have to go through to get a colonoscopy are a lot harder to get a colonoscopy because we're a volume restricted system. It's not fee for service, where it's much easier in other countries. And interestingly, the countries with the highest colonoscopy intervention rates, like the US, have got the lowest rates of bowel cancer. So the more colonoscopes you do, the more likely you are to detect bowel cancer and precancerous lesions and ultimately prevent cancer from actually occurring. What about cancer stage at diagnosis? Well, what we know is that New Zealanders, we sit in our symptoms, we don't talk to people about it, we don't have as good access to colonoscopy, and with the most recent data we've got, which is unfortunately a little bit old, we've got some new data coming in a few weeks, but our stage at diagnosis is much more advanced than comparable countries. New Zealanders are more likely to sit on their bowel symptoms to the point where it ends up as an emergency, and they end up in the emergency department than they are in the UK and in Australia. So we turn up later, we ignore our symptoms, and perhaps our doctors don't investigate our bowel symptoms quite as much. Okay? So we turn up later with a late presentation compared to other countries. We can change that. And the government introduced over the last term the program called Better, Sooner, More Convenient Healthcare. So this was about getting faster progress through the healthcare system in order to get a faster cancer treatment and hopefully a better outcome. Because surely treating cancer quicker must be a good thing. And what we found when we started looking at the Better, Sooner, More Convenient, when we started analysing how long it takes people to get their treatment, what we found in the Auckland region was that more than half of the patients, from the time they were diagnosed, hello, Mr. Jones, you've got bowel cancer, more than half the patients waited 2 months for their treatment after they told they had bowel cancer, rectal cancer in the situation, 2 months from diagnosis to first treatment. Don't know how you'd feel about waiting 2 months before your cancer that you knew you had was treated. I sure as heck wouldn't be very happy about that. Half the patients more than 2 months. So actually doing things quicker is a good thing. When we start to look at how you progress a hospital system more quickly though, why is it taking 2 months for people to actually get their treatment? Hospital systems are extraordinarily complex. They're extraordinarily cumbersome and clunky and difficult to change. Very, very difficult systems to actually move. And the pathways within which people go for their treatment are also extraordinarily complex. It's not quite a conveyor belt where you start here and you end up there and you have this, that, the next thing done to you along the way. There are so many different permutations and combinations of things that can happen to you along the way. And that's the sort of reason why it's taking so long. But could it be done quicker? Let's move quickly on. What we found was when we timed how long it took people to get from their operation to their chemo afterwards, there were significant delays in that pathway too. We thought we were doing pretty well. But one of the features that when we looked at it in detail that I found alarming was this. We found that the average delay, just because you're waiting for a letter to be sent from the surgeon to the oncology team, this took 14 days. So A surgeon dictates a letter in his clinic, sees you, I think this person needs chemotherapy, does on a tape. The tape stays with them for the rest of the day, eventually gets put on the secretary's desk. The secretary puts that in line with their work and eventually gets around to typing up that tape, types up that tape, checks it. Puts it back on the surgeon's desk, the surgeon's busy doing other things for a few days, eventually gets back to his office when he's got a quiet day, looks through his correspondence, oh yeah, I'll sign that, signs it. Goes back, puts it on the secretary's desk, it sits there for a wee while longer, eventually the secretary puts it in an envelope, posts it. And that process took, on average, 2 weeks. Okay. Totally and utterly unnecessary waits because we were using a tape and typing rather than something like an electronic referral system. And so we found this out and we went, oh gosh, that's terrible, we didn't think it was taking that long. And developed an online referral system, which would mean that from the moment of referral, the referral time was exactly 1/100th of a second, because it would then go immediately to a predetermined inbox. That was one of the changes that we could make as a response. In a response to a government policy tool of saying, work faster, and we analysed why we're working so slowly, and we're finding unnecessary delays in the system. And that was replicated in a number of steps. Additionally, people would sit on waiting lists for colonoscopy for a long time. They were given a priority, A, B or C priority, and they would sit and they would wait for their colonoscopy to come along. They just go, okay. How soon should I be having my colonoscopy? Well, you've been marked as urgent. And that was the system, just wait your turn. But in actual fact, again, the policy tool was, what we're going to do is we're going to say, if you're marked as urgent, you're going to have your colonoscopy within 2 weeks. If you're marked as semi-urgent, you have to have your colonoscopy within 6 weeks. The government, again, set targets. Again, doctors like me often flinch at the notion of targets. But actually a target said, this is what you have to do. Got us all around the table over the course of a year and a half. And worked through the criteria for defining a 2-week and a 6-week priority. Got us all to agree, eventually. And came up with the criteria. And now the government gets reports every month on the number of people who are called urgent, who get it within 2 weeks, the number of people who are called semi-urgent, and who get it within 6 weeks. So 6 weeks, we're still tracking about 45%. But that compares to before, when it could have been who knows. So we're now monitoring, we're seeing what's happening, we can actually look to say, well, we're not meeting these targets, which everyone agrees we need to, so perhaps we need to increase the colonoscopy numbers. So we're finally starting to get the tools. And again, when you say it out loud, it's pretty frightening that it's so underdeveloped in that way. But doing things badly, but quickly, still doesn't actually achieve very much. So, as well as better, sooner, more convenient, we'd quite like better. What about quality of care? Well, we've now developed national treatment guidelines. So we, again, got around the table and said, what are the minimum standards for how you treat bowel cancer in New Zealand? What are the minimum standards of care? And again, over the course of an 18-month process of committees and arguments and teleconference and so on, we developed a whole bunch of standards. We ended up with 23 different standards, and we thought, well, that's very hard to monitor on an ongoing basis, but we'll see what we can do. And then we monitored these standards and actually found that even monitoring standards in a consistent way is actually very difficult to monitor standards on an ongoing way. So there is no great big metadatabase that when you have your treatment in hospital, that your records get, your outcomes get measured in some central database you can then monitor. That doesn't happen. Your records are written in hand, and then how we get from that system to an understanding of a national view of what's happening is again extraordinarily complex. And we found that for monitoring the standards, it was a manual process for doing that. So we had to say, how did we do previously, not how are we doing, and how could we actually change and improve that along the way. So again, significant room for improvement. Proliferation of standards at the time. One of the problems with standards is often how we see ourselves is not how the world sees us. Okay? So, a good example. One of the standards was every patient who is diagnosed with bowel cancer should be discussed at a meeting of specialists, a specialist multidisciplinary team meeting. We've got representatives of every domain of cancer present and represented. So you, when you get your diagnosis, have the benefit of every expert, not just one, but every expert thinking about your case for a period in that meeting. Really good idea, and the target represented in the UK was that 100% of all patients should be discussed at an MDT meeting. So we looked at that, and I work in a tertiary hospital, university hospital. I'm in charge of the team meeting, and I thought we were pretty good. And I thought, yeah, my team works well. We're a functional team, we get on well, we talk, we bring all our cases to the meeting. Yeah, we'll hit that for a home run. We'll get close to 100% on that. And we did the audit, and we found that we were discussing 60% of our patients at a meeting. And my jaw just about hit the floor. And I said, there's no limits. Everyone can be discussed at my MDT. Why are we missing people? And the problem was not what we were seeing, as what we weren't seeing. Because we never know what we weren't seeing, and that was the problem. And so the solution then is, how do you identify someone even before they get to the meeting, and how do you flag them and make sure they get brought? Some of those patients are treated in the private sector, and they weren't being discussed. Why would your quality of care be worse in the private sector? Maybe it is. So making the meetings available to clinicians in the private sector to bring along to discuss the specialist meetings. Making sure that people who would only do an occasional bowel cancer operation every now and then was made sure that their cases were also discussed in that forum as well. Or maybe even perhaps more radically ensuring that people don't do just an occasional operation. They're limited to the hands of true specialists. And occasionally people are actually very sick with bowel cancer, and sometimes people are diagnosed with bowel cancer and die within a few days because their bowel's obstructed or they're too sick. And those people weren't being discussed. And we said, if someone turns up and they're really sick and they die from their bowel cancer, actually we still want to know. And we want to discuss that and see if there's anything else we could have done different. So through processes like that, we've now tried to get our number a lot more above 60. But I thought we were doing really well, and until we reflected and measured, we found out that we weren't. So better, sooner, more convenient. There are considerable ethnic inequalities in bowel cancer outcomes. So bowel cancer is one of the few cancers where Māori and Pacific have lower rates than non-Māori. For just about every other cancer you can think of, Māori have higher rates of the cancer than their non-Māori counterparts. Bowel cancer, they have lower rates. Interesting. But Māori, once diagnosed, have worse outcomes than non-Māori do. And what we found when we looked at this was that at every small step of the journey, Māori did just a little bit worse. So they're more likely to turn up as an emergency, less likely to be properly staged, more likely to have a permanent stoma, more likely to wait longer, and less likely to get chemotherapy for whatever reasons. They were doing just a little bit worse at every single step, and that added up over time and was cumulative. So again, we have to have programs to ensure that those ethnic inequalities are not amplified with the innovations in healthcare system design that we make. So recent initiatives that have happened over the last 4 or 5 years. The National Bowel Cancer Working Group has been formed, which is a national committee of experts designed to design and to direct bowel cancer policy and advise the minister. Direct access colonoscopy, that 2-week and 6-week thing I was telling you about. Increasing the use of CT colonography, that new technology we talked about. The fast cancer treatment indicators. Oh, and this bowel cancer screening pilot, not program pilot. Come back to that. The standards, but we still lack major investment in quality, I think. Still lack a major investment in quality. We're just told to do the same stuff for the same amount of money and get better results. That can only go so far. We did this 3-year national audit called the Piper Project, 5,667 patients, where we examined all the indicators of treatment that came along and how people did. I'm just going to leave that slide tantalising there because the results are going to be released in 6 weeks, and look out for it when it comes. There's some really interesting results about bowel cancer in that one. Can't tell you too much more about that just yet, unfortunately. What about screening, okay? What about screening? Now, why am I bringing this up? Because many people here will know that there's been a pilot screening program in the Wairarapa region going on for the last 5 years, and a recent budget announcement by the Minister said they're going to extend the pilot for the next 2 years. So, what do I think of that? Well, I'll tell you what colorectal screening is, okay? So for colorectal screening, as we looked at that picture earlier, a proportion of tumours, or most tumours, will actually bleed a little bit. And you've got something that comes through the bowel, your poo, and you can check that poo to see if there's any blood in it. And if you can detect a little bit of blood in the poo, then maybe you've got a bowel cancer, okay? There are other reasons why you can have blood in your poo too. You can have inflammatory bowel disease, you have bowel infections, you can have diverticular disease, you have hemorrhoids. But it might be a bowel cancer. And so if you detect blood in the poo, you can then go on and have a colonoscopy. That's what it's based on. And this test here, you get one of these lolly sticks, get a little bit of your own poo, and you smear it onto the paper, package it up and send it, and it gets analysed with blood. Now, One of the really interesting things about bowel cancer screening is that everyone agrees it's a good idea. And that's almost unheard of in medicine, okay? In breast cancer screening, there's still some professional debate about what the relative merits are, what the undiagnosed rates are, and whether actually early intervention makes a difference. For prostate cancer, it's extraordinarily debated as to whether or not there's actually any overall survival advantage, and whether we're just simply over-treating cancers that people would die from anyway. But with bowel cancer, if you get it and you don't treat it, you die from it, full stop, okay? You do not over-treat early bowel cancer. It does not happen, okay? So if you get a bowel cancer, you're going to die from it if you don't treat it. It's going to happen, not like prostate cancer. And all of the studies for breast cancer were done really badly as well, the research studies. They weren't very well conducted. But the bowel cancer screening ones, they'd learnt. They happened after the breast cancer studies. They'd learnt from all the controversy around breast cancer screening, and they did it properly. And there are now 5 randomised trials of occult blood testing and colonoscopy, and 3 randomised trials of flexible sigmoidoscopy. They all show the same thing. Screening saves lives. We all agree. We all agree. Only debate is around the detail of which particular test you should use SIGI or should use colonoscopy, but everyone agrees we should be screening. Okay? It's not debated. There is debate over the mechanism, as I said. I'll move on very quickly. And every other major country has been doing it. The UK started in 2000. Australia has been going from 2002, and in 2008 the then Labor government announced that we were going to move to a national screening program. I learnt just yesterday that actually, even though they announced it, they didn't actually attach any money to it. And then when the national government came to power, they rolled that back and said, no, we can't afford a national screening program. They didn't say that. They said, we're going to do a pilot. They didn't say they couldn't afford it. They said, we're going to do a pilot. And we're going to do a pilot for 5 years. We won't have to worry about it for 5 years. 5 years is up. They said, we don't want to worry about it for another 2 years. And so they announced an extension to the pilot, which is bizarre, because there's absolutely nothing we're going to learn from the next 2 years that we don't already know as to why that's happening. And there's only one reason why we don't have a national bowel cancer screening program now, and that's because the money's not been committed. That's it. Money. That's it. 12.4 million to extend bowel cancer screening pilot. Why? No one thinks that's a good idea. No one. One of the interesting things about politicians is they don't get bowel cancer because they do what's called an auto-colonoscopy. And perhaps if a few more of them had bowel cancer, we might actually have a bowel cancer screening program. Anyway, I hope over the course of the last wee while I've helped you understand that bowel cancer in New Zealand is a major health issue. Cancer is our #1 killer, and bowel cancer is our most common cancer. Okay? We're dying from it at a higher rate than we are in Australia, in the UK, and in Canada. We pick it up late, we don't investigate it very well, we're a little bit slower to the blocks. We don't have as many good drugs for advanced bowel cancer as other countries do, and we don't have a screening program. My view is that when you've got the world's biggest problems, you need the world's best solutions. And what we need is a little bit more readiness to talk about it and a wee bit more ambition. And then I think we can turn it around. Thanks very much.